This technical note highlights a step-by-step guide and preparation of a Talus allograft for the treatment of a large off-track Hill-Sachs lesion. This case was performed at the Steadman Clinic in Vail, Colorado. This patient is a 29-year-old right-hand dominant male with complaints of recurrent anterior instability of the right shoulder with multiple low-energy dislocation events with day-to-day use. His treatment plan consisted of a right open Bankart repair and humeral head bone grafting with a fresh osteochondral Talus allograft. On plain films, there is a moderate-sized posterior superior Hill-Sachs lesion and no evidence of early glenohumeral osteoarthritis. Advanced imaging demonstrates no glenoid bone loss with the best fit circle method as well as a large off-track Hill-Sachs lesion measuring 25% of the humeral head diameter. MRI confirmed an associated anterior-inferior Bankart injury. Through a standard delta pectoral approach in the beach chair position, the posterior superior impaction defect of the humeral head is fully exposed. Once fully exposed, the defect is prepared for bony incorporation with a microsagittal saw and power rasp to abrade the impacted and sclerotic edges of the lesion back to a smooth, bleeding surface of cancellous bone. The size of the defect is measured using a calibrated probe or ruler. Both the medial and lateral aspects of the talar dome are inspected for the optimal radius of curvature. A sharp towel clamp is utilized for graft control. The 4 major cuts are marked prior to being cut with a microsagittal saw. Typically, the lateral articular surface and lateral gutter are selected as the most favorable match for radius of curvature. Cut 1 consists of a longitudinal cut along the lateral edge of the talar dome, perpendicular to the articular surface to remove the cartilage from the lateral fibular gutter. Continuous irrigation is used throughout to keep the graft cool and to minimize the risk of thermal necrosis to the articular cartilage and underlying subchondral bone. Cut 2 is made parallel to the articular surface of the talar dome and perpendicular to cut 1 to help set the depth of the osteochondral allograft, which is typically 16 to 22 millimeters from the apex of the talar dome. Anatomic landmarks to assist with the depth include the junction of the talar articular surface, talar neck anteriorly, and the posterior margin of the talar cartilage posteriorly. Cut 3 is critical in order to appropriately match the sphericity of the humeral head. This cut is made at an oblique angle relative to the axis of the articular surface of the lateral talar dome, not perpendicular to the floor. It is important to understand the orientation and importance of the obliquely oriented cut 3 to match the sphericity of the native humeral head. Prior to cut 3, the osteochondral allograft has a flat contour. Cut 4 is the final cut to help establish the articular surface, which creates the lemon wedge shape following the full length of the articular surface of the allograft to the apex of its concavity. It is recommended that the surface width of the allograft be measured approximately 4 to 5 millimeters wider than expected and then sequentially contoured down to size as appropriate, typically 8 to 12 millimeters. Care should be taken to remain medial to the lateral downslope of the talar dome cartilage, as inclusion of this region may compromise articular conformity when the graft is seated into the humeral head defect. The graft is then remeasured and incrementally contoured to match the prepared defect site. The graft is pulse lavaged for approximately 10 minutes and then allowed to soak in biological augmentation. Once the graft is appropriately contoured, provisional fixation is secured with 2 or 3 2.4 millimeter Kirschner wires placed through the graft in parallel orientation to facilitate handling of the allograft and later screw fixation. Immediate postoperative plain films are obtained to ensure appropriate fixation, graft contour, and screw trajectory.